Hi, good evening. I'm back with a very important topic for postgraduates as well as for practitioners, that is endometriosis. This week is called Endometriotic Week, and actually I'm doing a lot of talks in connection with this. On March 9th, I'm talking at Manipal as a endometriosis awareness program. I'm also a part of the multicentric study on endometriosis phenotypes and genotypes, and that is also a reason why I'm talking on endometriosis today. Obviously, there are a lot of things to be discussed in endometriosis. Infertility is the main aspect of it. Pain is another, and there are a lot many things. So that's why I will not be able to finish in one class. So I made it as part one straight away. Let's go and learn the different management aspects in endometriosis. As I told you, I have incorporated February 2022 ISHRE guidelines as well in this talk. I hope it will enable you to answer in recent advances. Endometriosis, the yellow ribbon, all of you know that. ISHRE February 2022 guidelines with regards to diagnosis. Before I talk on management, we need to know about the diagnosis. My famous sentence for all undergraduate students, which they actually make fun of me, is that the gold standard to diagnose endometriosis is laparoscope. In fact, recently I met a student who was my ex-student some 15 years ago. He was the student in Manipal, and he met me, and first thing he said, "Sir, gold standard to diagnose endometriosis is laparoscopy." Let's see what ISHRE February 2022 guidelines say about it. Laparoscopy is no longer the diagnostic gold standard. Are you shocked? I was a little bit shocked. But let's see. Whenever ISHRE comes up with guidelines, they don't simply talk. They would have done a thorough review of literature. They would have gone through meta-analysis, systematic reviews, and everything. What they say is that it is now only recommended in patients with negative image results and or where empirical treatment was unsuccessful or inappropriate. What it means is that endometriosis can be diagnosed with fair accuracy with symptomatology alone, the famous 5 or 6 Ds: dysmenorrhea, dyspareunia, dysuria, dyschezia, and maybe even dull aching pain. Of course, the undergraduates used to say, you can add one more D, the death. Of course, death is not a complication, it is a certainty. So with good accuracy, you can diagnose endometriosis with these symptoms. And of course, accompanied infertility will prove the diagnosis. Ultrasound, yes, if you have nice chocolate cysts, you can make the diagnosis. It's very easy. If there are adhesions also, you can elicit that by ultrasound by en masse movement of the uterus and adnexa. If it is frozen pelvis, it's sometimes very difficult to make out. Or if it is very early endometriosis, again, it's very difficult to make out by ultrasound. Those are the cases where the imaging results are negative, probably laparoscopy is required. In other words, laparoscopy is not the first line diagnostic tool. In fact, they have said it is no longer a diagnostic gold standard. Other thing is, you can start treating endometriosis based on the symptomatology of the patient. And if the treatment is unsuccessful or inappropriate, that is the time probably you can do a laparoscopy to find out whether the problem is really due to endometriosis, or whether it is a case of PID, or whether it is any other thing, adhesions due to any other reason. So I hope it is very clear now. It is the latest guideline. There are many more things in ISHRAE guidelines. As I talk, I will be talking about that with regards to infertility, with regards to pain management, and so many other things. So as far as diagnosis is concerned, this is the latest. So as I said, what is recommended to diagnose is symptom diary, questionnaire that can give you early diagnosis. You can have low diagnostic accuracy with V or DIE, ultrasound or MRI for form imaging. Negative results does not exclude, of course. Empirical treatment also can be used to diagnose. Something like in the past, we used to say tuberculosis is very difficult to diagnose. Empirical treatment itself is a diagnostic thing. You give 6 weeks of anti-tubercular treatment, and if the patient improves, that indirectly proves that she was a case of tuberculosis or she is a case of tuberculosis. Laparoscopy only if either of above not diagnostic. HPE at laparoscopy negative does not exclude. So in other words, endometriosis is almost like an empirical diagnosis. Instead of empirical treatment, it is an empirical diagnosis, I can say. Because HPE at laparoscopy or laparotomy, even if it is negative, it does not exclude endometriosis. That's what ISHRAE has told. So you can diagnose, in other words, mostly by the patient's symptomatology. If you find chocolate cyst, if you find some of the other evidence of endometriosis, that's fine. Even if it is absent, you can treat it as a case of endometriosis unless she does not respond to the treatment. What is not recommended definitely is biomarkers, though they are trying to develop lots of biomarkers. There are so many advances research going on. Some people even say hematocrit, some people say even iron, so many biomarkers, ferritin, so many things are being recommended, but as of now, none of them are proven. That's why ISHRAE does not recommend it. There is no evidence whatsoever in following situations. Like you may offer follow-up and psychiatrical support when diagnosed early, although benefits are questionable. Let's move on with the management now. There are mainly two problems to be managed in endometriosis. What are they? Number one is infertility. Number two is pain. Now this pain, actually, I should have put it as first, but since today I'm talking on infertility, I have put infertility as first. Because infertility question comes only if the lady is desirous of having a child, married or unmarried, whereas pain, whether you are desirous of a child or not, can be there right from a young to the middle-aged to elderly lady. So that is very, very important with respect to endometriosis. Anyway, today I'm going to talk on infertility, basically. The standard of care in general for endometriosis is surgery. Of course, whenever there's a big chocolate cyst, when there are adhesions, when there are endometriotic patches, surgery definitely offers a lot of relief and help, plus medicine. Of course, this is the standard of care for most of the diseases, surgery plus medicine or medicine plus surgery, whichever way you look at it. So let's see how we must make use of either of them or both of them with respect to infertility. So as far as the standard of care in infertility, instead of saying surgery plus medicine, it has now become surgery plus assisted reproductive techniques. You may ask me, why did you remove medicine? The answer is here. Unfortunately, the medical therapies almost exclusively limit reproductive options due to their contraceptive effect. After all, what are you going to use in endometriosis as a medical enough management? It is either progesterone straight away, or something which induces progesterone, or if it suppresses gonadotropins altogether, in which case there will be suppression of estrogen, which is thought to be a manure for flourishing of endometriosis. But don't you think that will come in the way of fertility? When you use progesterone either directly or in the strongest form, the norethisterone form, or if you use a bit stronger, that is danazol, or much more strong, that is GnRH analogs, all of them will actually come in the way of fertility. So that's exactly why there is no role for medical treatment. It is a waste of time. Cochrane review of 23 trials, including 3,000 women, demonstrated that no difference in pregnancy rates if you pre-treated these women with medical management before assisted reproductive techniques. With preceding ovulation suppression with oral contraceptives, progestins, or GnRH analog in subfertile women with endometriosis. Very rarely, Cochrane review comes out with very concrete conclusions. Here is one situation where Cochrane review has clearly said there is no difference in pregnancy rates, so there is no point in actually giving these things preceding ovulation induction. Oral contraceptive pills, progestins, and GnRH are very effective in treating symptoms of endometriosis before and after pregnancy. What they mean is the symptoms such as pain and other symptoms, what I told about 5Ds, before and after pregnancy, but not to induce pregnancy or to treat infertility. But pre-treatment with these agents does not appear to improve fecundity. Very clear conclusion by Cochrane. Implementation of medical management will only delay attempts at conception. Why I'm harping and stressing it again and again, because many people believe that after surgery, you have to suppress endometriosis before you start ovulation induction. In fact, when I gave this talk some other place, there was a Japanese professor who said he believes in giving progesterone at least for 3 to 4 cycles. And there was a lot of controversy, debate. I retracted from the debate because I felt at one point of time, there's no point in debating because things are very, very obvious and very clear. By giving progesterones and progestrogens, you are only delaying the conception. Let us look at the ISHRE guidelines 2022, February. What do they say? Because the previous Cochrane review was 2007, if you could make out there. It is 2022, current, just last month. Extended GnRH analogs prior to ART no longer recommended. Full stop. Due to unclear benefits. Endometriosis fertility index was added as a step in the treatment as it can support decision making. Instead of blindly giving GnRH analogs, you may use this endometriosis fertility index for the added benefit. What is this endometriosis fertility index? Here, as you can see, endometriosis fertility index, there is a surgery form, least function, LF, score at conclusion of surgery, at the end of surgery. So there is a different score that you give. If it is normal, the score is given 4. If it is mild dysfunction, 3, moderate 2, severe dysfunction 1, and absent or non-functionally 0. Every organ has to be, reproductive organ, as you can see here, should be evaluated and the score should be given accordingly. Left tube separately, right tube separately, left fimbria, because fimbria is the most important part of the tube. If fimbria is damaged, you cannot do much about it. That's exactly why don't do fimbriectomy as a method of sterilization unless you want to be 150% sure that the person does not become pregnant again. Ovaries, both left and right, and you can give here the lowest score for the left and the lowest score for the right, and you can see here. To calculate lowest score, add together the lowest scores for the left side and the lowest score for the right side. If an ovary is absent on one side, the lowest score is obtained by doubling the lowest score on the side of the ovary. So if let's say one ovary was removed for whatever reason in the past, so you can simply double the score of the opposite side and put it there. So here you can have little more elaborate fertility index where they also take into consideration historical factors like age. If the age is less than 35, 2 points, 36 to 39, 1 point, more than 40, 0 point. Obviously, as the age advances, fertility also comes down, isn't it? Years of infertility matters a lot. How long you have been infertile. If the years is less than 3, 2 marks, more than 3, obviously 0 marks. Prior pregnancy, if there is a history of prior pregnancy, obviously the prognosis is better, 1 marks, but if there was no pregnancy, 0 marks. So what is the total historical factor score? Coming to surgical factors, the factor description you have to put the LF score. If LF score is 7 to 8, it's good score actually, 3 points. If it is 4 to 6, moderate score, 2 points. If the score is 1 to 3, it's a very poor, low score, 0 points. ASF endometriosis score, lesion score, if it is less than 16, this I'm going to come little later, probably in the subsequent slide. That is American Fertility Society endometriosis score. See, this endometriosis fertility index is so wonderful that it has given its own scoring system, plus it has also incorporated this. I am very shortly going to talk about this, right? Here it is 1 mark, and if the score is more than 16, it is 0 marks. So AFS total score, if it is less than 71, is 1 marks, more than 71, it is 0 marks. So altogether, you are going to have, that is endometriosis fertility index is equal to total historical factors, this one, plus total surgical factors, this one. So historical plus surgical is equal to EFI score. Now, based on that EFI score, as you can see here, the estimated percent pregnant possibility. The score is good, means the possibility is up to 80%. If the score is poor, then it is less. And also on the x-axis, you can see the months. Well, this you cannot maybe just like that remember, but you have to have it on your mobile or in an infertility center. They will do this scoring elaborately. It will take time. You cannot just, by heart it and remember it all the time. What are the principles of treatment? Decisions should be individualized and consider age of the patient, which has already been incorporated in the fertility score. Clinical presentation, that means historical. Severity of symptoms, again, historical points. Location and extent, where American Fertility Society scoring we are taking. And here, age, location, and extent is important. And I say age and location and extent is important, I come to staging. 1 and 2. Stage 1 and 2, which is also considered minimal and mild endometriosis. Stage 1 minimal means it is just superficial endometriosis in the peritoneum, 1 to 3 centimeter, only 2 marks. Right ovary, superficial endometriosis less than 1 centimeter is 1 mark. Flimsy adhesions, 1 mark. Total points is 4. This is called minimal endometriosis. Like that. Whereas stage 2, which is called mild endometriosis, now instead of superficial, peritoneum becomes deep, more than 3 centimeters, 6 marks. Right ovary, it is same, but now left ovary is also involved, maybe superficial, so total points is 9. Like that. Now stage 3, which is considered moderate, peritoneum is obviously deep, cul-de-sac now coming into picture. If there is partial obliteration, 4 marks, left ovary, deep endometriosis, 16 marks. Total points becomes 26. Stage 3, another way of looking at is peritoneum, superficial right tube and right ovary. Both are involved now. Left tube and left ovary is also involved. Total points is 30. Somewhat like this. Whereas severe stage 4, peritoneum is deep, cul-de-sac is completely obliterated, right ovary, left tube, left ovary, all are involved. Total points will be 114. Whereas another picture, you can see peritoneum is 4, left ovary is 32, dense adhesions, left tube. This is also very difficult for all of us to remember, but most of the centers, laparoscopic centers, will have an automatic printout of them, and you have to keep on ticking them, and you have to do the total score. This score can be incorporated in the fertility score as well. Now let's see, with all that, why should there be infertility with endometriosis? In stage 1 and 2, which is supposed to be minimal and mild, the disease incites inflammatory response due to overproduction of prostaglandins, metalloproteinases, cytokines, and chemokines. So it's inflammatory response that is giving rise to the problem. There are also macrophages and natural killer cells, which may both eat up the gametes, both ova as well as sperms. In addition to that, there is impairment of ovarian, peritoneal, tubal, and endometrial function. What else is left? Ovarian, peritoneal, tubal, and endometrial function. All are impaired, leading to defective folliculogenesis when ovaries function is impaired, defective fertilization because it has to come through the tube and get fertilized there, and or defective implantation. At all the 3 levels, endometriosis will affect. So it's very easy to remember if somebody asks you, why should there be infertility? Because there is inflammatory process that is going on, as well as impairment of function at ovary, tube, and endometrium, leading to defective folliculogenesis, fertilization, and implantation. At all the 3 levels, there is problem. Whereas in stage 3 and 4, in addition to chemical and immunologic mechanisms of stage 1 and 2, that is inflammatory process, where I said cytokines, chemokines, macrophages, natural killer cells, all are increased, and there is some sort of dysfunction. There is distorted pelvic anatomy and adhesions. There is a mechanical problem now seeping into because of total adhesions and plastered pelvis. Stage 4 is almost plastered pelvis. There is distorted pelvic anatomy and adhesions. Impaired oocyte release as well as pickup because the ovary is totally engulfed within the adhesions. So there is no release of oocytes. Even if there is release, there are adhesions, febrile phimosis maybe, and the pickup is also at problem. Alter the sperm motility, fertilization, and embryo transfer because of the kinking of the tubes, maybe dysfunction of the tubes. There is problem with the sperm motility and fertilization, and after fertilization, the embryo is supposed to go back to the uterus. That is also hampered. And it can cause disordered myometrial contractions as well at that level. So again, in stage 3 and 4, in addition to the problems of stage 1 and 2, there are additional problems of distorted pelvic anatomy and adhesions. So with all that, how do you manage the infertility? Obviously, surgical management. I have already told you no medical management. It is only surgical management. Most of the available data is for patients with mild to moderate diseases, and results are mixed. There are no RCTs to determine the efficacy of surgical management of moderate to severe endometriosis to date. Yes, surgical management is a good option, but even there, most of the studies are for mild to moderate, where there were maybe just chocolate cysts, flimsiadations, adductolysis were done, femorolysis were done. But for a moderate to severe endometriosis, whether the surgical treatment has been successful or not, no RCT has evaluated that. Canadian collaborative group of an endometriosis with 341 subjects with minimal or mild endometriosis randomized into only diagnostic laparoscopy or laparoscopic ablation or resection. It's a very old study, but since it is being published in New England Journal of Medicine, it is still holding and still a standardized one. They found that significantly higher cumulative pregnancy rates in treatment group versus lower in the other group, suggesting enhanced fecundity with surgical treatment of endometriosis. Just treatment with surgery itself will enhance. No evidence that the outcome is affected by the method of ablation. How it doesn't matter by how you ablated them, whether by electrocautery or by laser. Italian RCT 101 subjects with similar design showed that is mild or minimal endometriosis randomized into diagnostic laparoscopy or laparoscopic ablation or resection. No difference in live birth rates, of course, because it was 19.6 versus 22.2. What did Cochrane meta-analysis 2010 say? There is a benefit of surgical treatment compared to diagnostic laparoscopy alone for clinical pregnancy and ongoing pregnancy after 20 weeks. Again, very conclusive remarks by Cochrane there. Is surgery alone enough though? Surgical management is largely guided by patient symptoms, that is dysmenorrhea, dyspareunia, dyschezia, chronic pelvic pain. While symptoms improve, there is much debate about the utility of surgery alone in the management of endometriosis-related infertility. So, there may be a role for treatment of mild to moderate disease to improve fertility, but overall pregnancy rates, both with and without treatment, remain very low. Surgery is better than no treatment, of course, but surgery alone may not be best treatment to improve fertility. So what to do? That's exactly why, if you recall my earlier slide, surgery plus ART. So cystectomy, there are added concerns. Suppose you do a surgery, yes, it may improve fertility, but if you do cystectomy very aggressively, further decrease in ovarian reserve can happen. We have done a study in Manipal and proven that. Retrospective data suggests a significantly lower antral follicular count and ovarian volume. In women without symptoms, diagnostic laparoscopy to look for endometriosis is of very little benefit. That's exactly why Sri now said, don't do diagnostic laparoscopy as a first choice or even as a gold standard. Routine removal of cyst is not recommended to improve fertility. So that is again another issue, unless it is very big in coming in the way of follicular genesis or in the oocyte pickup, there is no need to remove every single cyst. Up to 3 to 4 centimeters, we can just ignore them. So major fertility benefit achieved shortly after first procedure. That's another Cochrane observation, 2015-14, irrespective of the post-surgery fertility enhancement treatment. Women who do not conceive after first surgery have worse disease and their pregnancy success is less, regardless of repeat surgical intervention. What it means is the first surgery has to be the best surgery. Once you keep on doing surgeries, the complications increase, the adhesions will increase, and everything will be worse. So people have suggested surgery plus IUI, because surgery alone may not be of benefit. There was minimal added benefit when combined with the controlled ovarian hyperstimulation and IUI. Unassisted CPR with laparoscopic cyst wall excision was 61% versus cyst wall ablation was 23% within 2 years of laparoscopic treatment. IVF for endometriosis. There is little doubt that the most effective treatment for infertility associated with endometriosis is IVF. Over 5,600 IVF cycles in United States, resulting in over 1,400 live births. But The meta-analysis of 22 studies with 2,000 IVF cycles, endometriosis over 4,000 cycles with other indications. What did they say? Pregnancy rates were significantly lower in patients with endometriosis and in particular those with severe disease. Now don't get confused. I am not confusing you. IVF is the best treatment for endometriosis. There is absolutely no doubt. But even with IVF, the success rate in endometriosis is lower compared to IVF for other indications other than endometriosis. Specifically, the oocyte yield, fertilization rates, implantation rates were significantly decreased in patients with endometriosis. What it means is, suppose there is another indication, for example, low sperm count without any female factor, the success rate with IVF is better. If just a tubal block for non-endometriotic reason, success rate is better. Stage 1 and 2 options, of course, now do not appear to negatively impact outcomes. So natural conception can be tried. Ovulation induction and intrauterine insemination can yield results, but IVF and ICSI are still the best options. Whereas in 3 and 4, they have negative impact even on ART outcomes, but only IVF ICSI is the option here. No IUI, no natural conception. Pre-IVF cystectomy in select cases only. Aggressive lysis of adhesions is accompanied by adhesion reformation, and that may hamper ovum pickup. You have to be very careful. Endometrioma, now I'll talk about that. Medical therapy does not resolve endometriomas, though people claim that with the Diagnostic, the endometriomas shrink, but not really, they will not go off. To protect ovarian reserve, asymptomatic and small, which is less than 5 centimeter endometriosis, can be left in place. Earlier, I used to say 3 centimeters. Then I made it 4 centimeters. Now they say up to 5 centimeters, ignore it. Symptomatic but big. Big means more than 5 centimeters. Endometriomas coming in the way of OPU needs surgical removal. Cystectomy is the best choice. Drainage and coagulation is the next best choice. But some people do only drainage if there is dense adhesion. So I think I will stop the class here and keep management of pain for tomorrow.